From Eyewitness News, this is Newsmakers.
At a reported 6,000 hits a minute, the Rhode Island Healthcare Exchange website, the pipeline for President Obama's Affordable Care Act, crashed on day one. The lapse was only temporary, and in reality, it was a pleasant surprise for HealthSourceRI.com administrators who weren't sure how many people would be interested in exploring their Obamacare options. But the true test is on the horizon. How many Rhode Islanders will sign up for the healthcare exchange, and will it be enough to make HealthSource Rhode Island worth it? Our guest this week on Newsmakers, HealthSource RI Executive Director Christine Ferguson.
Good morning. Welcome to Newsmakers. I'm Tim White. Joining me on the panel, WPRI.com reporter Ted Nisi and Eyewitness News analyst Arlene Violet. Good morning, everyone.
Morning.
Christy, welcome back to the program.
Great to be here.
How are you sleeping?
Very well.
All right, good. All right, so we tape on a Friday morning. The HealthSource RI website has been up and running into its fourth day. How many people have signed up for health insurance plans?
So right now we've had 366 applications that have been completed and processed. We've had almost 4,000 calls. This is the 2-day total. I don't have the 4-day or the 3-day total.
Okay.
We've had almost 4,000 calls, almost 100 folks walking in, and close to 20,000 unique website visits in 2 days. And 2,000 accounts were created, so that started the process for people.
Let me ask you something. Of the 366, is that individuals or does that also include small businesses?
It's everything. It's everything combined. I don't have it broken down right now.
Do you know what the level of interest is from the small business end at all?
Well, I can tell you we've been across the state for the past 30 to 60 days, and there's been tremendous interest. We're working closely with the broker community, and they tell us that there's a lot of interest. So the renewals for small businesses will start January 1st. And so really we probably won't know until November, December.
What's the goal? How many people do you need?
Our target right now is between 70 and 100,000 people in the first 18 months. We'd love to beat that target. There are 15,000 small businesses in Rhode Island that offer health insurance to their employees. And we're hoping that a good portion of them will explore the exchange and choose the full employee choice model that we've done here that is unique to Rhode Island.
And is that, as Tim sort of alluded to this, when you say 70 or 100,000 people, is that on the individual side, or is that when you add in the people from the small businesses? Because I think a lot of people are focused on the individual market, but you're hoping to get a lot of take-up on the small business side.
Yes, absolutely. We're the only state in the country that's really focused on the small business side, and the reason that we did that was small business rarely gets a break, and this approach of being able to go to the exchange, set an amount that you can afford, find a plan that fits that amount, and then allow your employees to choose from the other 15. That's a very unique, and the only place you can get it is on the exchange, and large companies don't have it either. So it's the first time that really we've led with small business, I think, in the state for a long time.
Now you need a mix here. I mean, of the 70,000 to 100,000 people that you need in 18 months, do you know how many need to be young and healthy, and you hope they're not going to rely on healthcare as much as opposed to those who might be tapping into the healthcare system more?
So the back end of the exchange, these questions are great because it highlights the fact that one component is the component everybody's focused on right now, which is, go on, you sign up, all of those pieces. But the equally, if not more important component is how do we manage and work with our healthcare insurers and our providers and consumers around making sure that the way that the plans are designed really help manage cost. And so one of the issues that people have really been concerned about across the country is if you don't have enough young people in the overall pool, that costs will go up. But that's always been the case. I mean, it's not new now all of a sudden. So I think when we look at it across the board, you'll see that there will be quite a few people in that lower age group who will take up.
But do you know how many you need as part of that 70 to 100,000?
No, it's not a question of need or not need so much as it is a question of how the cost of healthcare.
Yeah, it
moves,
relates to the premiums,
right?
and let's talk a minute about the premiums, because in Rhode Island, we really have high premiums compared to the rest of the country and the average. That's being cited right now. I looked at various states, and for example, take Florida, that has a lot of gray hairs, like me.
Who are on Medicare.
$174 less for the groups, before they go on to Medicare, et cetera, than here. $100 less for age 30. In Florida, because they have competition. What happened here in Rhode Island? We've got the neighborhood health plan, but they're a bit player. It's the total dominance of Blue Cross Blue Shield, and a lack of competition tends to juice up the cost of premiums. Why didn't we get more competition? We've had a couple of years to prepare for it.
Well, we haven't really had a couple of years to prepare for it. We've had, we have the market that we have in Rhode Island right now, and we had Tufts. Tufts will come in on January 1st of 2015. Connecticut Co-op.
They haven't applied yet, though, have they? Has that been processed? So that's still theoretical, isn't it?
No, they're in the market already. They've agreed to come in.
To come in,
yes.
But not. They're not available on the health exchange at least till 2015. They're not there now, right? And how about United?
United is there. United
not on the health exchange now. When are they coming in?
Well, United is on the small business side of the health exchange, and the product that United offered us was not so much a United product as a subsidiary of United, and so we were really looking for good quality. And
why are the premiums so high compared to the rest of the country?
The premiums are high compared to the rest of the country in New England generally. In terms of Rhode Island, if you compare us to New England, we're in pretty good shape. We have, however, we're on the cusp of some real possibilities in terms of reduction in cost, and the single most important thing to make that happen is that individuals make the choice as opposed to employers. And so we spent our time really laying the groundwork for the next step. And the next step, which starts now, is a negotiation of new arrangements in terms of how people get care so that we can bring costs down. That new arrangement piece, that can't be done unless individuals are the ones making the choices, because we tend to regulate when somebody else makes a choice for you. In this case, when people come to the exchange, if we get the volume of small businesses that we need, then I think you'll see some experimentation around different ways of getting care. We've got a very robust call center, probably one of the best in the country, that is designed not only to help people choose plans when the one time, but also throughout the year, to work with them on which provider to choose, how to look at what their benefits are versus what kind of providers might be best suited for them, and questions that they have throughout the year. So we've laid the groundwork in this build of an entity, and the groundwork really is about understanding that premiums are only one part of the equation. The other part of the equation is how you get care, and that's going to bring premiums down, and that's where we have the most ability in this state to really use our size and to use our ingenuity to make changes in that arena.
Chrissy, I want to turn back to the news of the week, the launch. You mentioned you had 366 in the first 2 days. Connecticut only had 373, so Rhode Island, despite being smaller, is actually pretty close. And the reports about the federally run exchanges, and people can Google that if they want to understand all the differences, but are pretty grim. They're saying maybe single digits because the technical problems are so troubled. Even Ezra Klein, a supporter who writes for the Washington Post, had a devastating piece this morning about how bad the federally run exchanges. We again have a state-run exchange. What did we do differently that the federal government didn't, apparently, that people are getting through the process more often in Rhode Island?
So I think that, Arlene, you can probably relate to the length of time that we in Rhode Island tend to think of ourselves as not so great compared to everybody else. This is an example of where the leadership in the state, the governor, the lieutenant governor, the legislature, the CEOs of the health plans, the provider groups, everybody really came together, and we made a decision to do something as a state. And when we made that decision, we went all in. We went all in, and we designed this to suit the needs of our population and to not look for perfection on the first day, but rather to build in all the backups that would be necessary so that if we didn't get perfection, we wouldn't have a crisis.
But Barack Obama presumably wanted this to work too, and his administration was in charge of those federal exchanges.
I can't speak for them, but I can speak for us. And what I can say to you is that I am so proud to be from Rhode Island right now, because we did something that I don't think anybody else did.
Christy, I want to play something for you right now. We interviewed a young man named Sean Clough and asked him whether or not he was going to sign up for health care through the exchange. And here's what he had to say. Take a listen.
Well, compared to the costs of the health care,
you can't hear him right now, but
to me, it's a no-brainer. Okay, I'll have to pay the $95. Does it sit well with me that I am struggling to pay my own bills? Then the government is saying, well, now you have to pay a $95 fee if you choose to not spend your money on a certain product. Yeah, that's frustrating.
All right, just so to recap there, he said instead of going into the exchange, he's going to pay the penalty of $95 because that's a heck of a lot cheaper than a couple of $100 a month in healthcare. You need that guy. He's a young man, hopefully healthy, Sean, but you need him in the exchange. What do you say to him?
Well, first of all, we need him in the market because he needs to be in the market. In other words, if he goes home tonight and he gets into a car accident, or he's painting his house and he falls off the ladder, the fact of the matter is that we've made a decision as a country that we're not going to let him bleed to death in the street. He gets to come to the hospital, he gets to have care, he gets to get stabilized.
Yeah, the hospital's not going to turn him away, okay?
They're not allowed to turn him away.
That's right. Legally, they can't do that, so why would he buy in? He's going to be, he can walk into the emergency room and get that arm cared for.
As his parents will probably tell him, they can't turn you away, but they can ruin your credit. So the issue is that as we go forward, what all of us are going to learn, and one of our core values is, I don't want to force him to do anything. What I want him to do is to understand what the ramifications, what the choices are. By choosing not to have health insurance, you take a series of risks. He may or may not be aware of what those risks are, and we need to make sure he is. And then at the end of the day, if he makes that choice, he makes that choice, right? In the places that, Rhode Island, when I left state service in Rhode Island in 2001, the rate of uninsurance in Rhode Island was somewhere around 6%. For kids, it was like 3 or 4%, right? People generally want to get health insurance. There's a bunch of people who won't, but it's a relatively low percentage. Our job is to make it affordable. And this year, that it might not be something that he wants to spend money on. But next year and the year after, I think we'll get to the point where he understands what the ramifications are and the risks are to him, and where it's priced in a way that he will feel comfortable getting it.
All right, we got to take a break here on Newsmakers. When we come back, we're going to have an important conversation on what all of this costs. Our guest this week is the Executive Director of HealthSource Rhode Island, Christine Ferguson. Stay with us. You're watching Newsmakers. Welcome back to Newsmakers. I'm Tim White. To my right, Ted Nisi and Arlene Violet. Our guest this week is the Director of HealthSource Rhode Island, Christine Ferguson. Ted. Christy, we were talking, I know you said how proud you are of your team, but we're not immune in Rhode Island to the problems in the federal side of this. I know the federal hub, which verifies people's identities, your spokeswoman told me was working only intermittently. So first, I want to know, how serious a problem has that been for HealthSource this first week, having our exchange get what it needs out of the federal government? And do you think more than 366 people might have wanted to sign up this week?
Yeah, it was a really disappointing component and very unfortunate. I mean, I understand, but it's unfortunate for us. What we've done is put a couple of kind of backstops in place to do some things manually that will help. But at the end of the day, that data hub is going to have to work more effectively, or we're going to have to do everything manually, which is fine. We can do that, but we're going to have permission to do it. So there are, I can't remember how many people, I actually don't know if I have the number, how many people were affected, but I know that we've had numerous people who got caught up in that. And what we'll be doing is going back and following up with them. So I don't think in the long run, it's not a killer, because coverage doesn't start until January 1. It's disappointing, but.
Yeah, last time you were here, I asked about the $25 million projected for the bureaucracy.
Right.
And I don't mean that pejoratively, but
I understand.
But just to get this
for
going.
The customer service.
And I asked you, why wouldn't we just join Massachusetts? And that time your answer was that we were going to have such quality elements, that is quality, not just costs, etc. Could you point out to me right now at least 2 examples of improvements over Massachusetts' plan in order to justify our separate program, and what's the differential in what Massachusetts charges versus what we charge under their Health Connector?
So what they charge for the overall operational
cost?
You mentioned,
you said that we were going to have such quality programs, we were going to offer more. So I shouldn't be doing apples to oranges, because the costs would be different, because we were going to offer much more than Massachusetts.
Well,
so our bureaucracy was okay rather than join them. So I'm just looking for 2 examples.
So as an example,
what do we offer they don't, and how much are we paying more?
Our call center is designed to serve all of the citizens of Rhode Island, to take insurance complaints, discuss provider questions throughout the course of the year. It's not designed.
Theirs do too. I mean, I was on I was on the Health Connector yesterday, and they've become central. And of course, they've been around since 2006. So they don't have the big potential volume, but I'm just asking for the quality of the plan. What are we ensuring that Massachusetts doesn't? Because you pointed out that we have better coverage, and that's one of the reasons why we didn't want to join Mass, because they were faulty in some of their coverage.
I may not have communicated what I was trying to say very articulately. But it's not just the plans and the choosing of the plans. It's really throughout the course of the year, the support that we provide to people around provider choices and those kinds of things, number one. So that's contact center and customer service. I think that the customer service focus in Rhode Island, as we go through the next 6 months, we're going to prove to be one of the best in the country.
Yeah, but then you're looking for anywhere from 18 million to 24 million. After that, by that time, there should be some homeostasis relative to people at least seeking.
Not at all. If we're really moving on cost and trying to make change in the system, homeostasis, that doesn't exist.
No, in terms of customer service.
No, but homeostasis and customer service, the quality of the customer service to be able to respond to the changes that we're pushing in the system, that's constant upgrade, constant training, constant support, because the single most important thing that's going to happen here, and the thing that is going to be unique to Rhode Island, is that each and every person in the state is going to understand over the course of the next couple of years how their choices every day, from their provider choices to their plan choices, how those choices affect costs.
So you're going to take over.
Well, hold on. I want to have a conversation about the administrative costs and the finances here. The federal government footed the bill to get things up and running, but starting in 2015, Rhode Island will have to find the money to cover the full cost of operating the exchange.
Right.
How are they going to find that money? Is that taxpayer dollars? Is that ratepayers?
This is absolutely going to be a conversation for the population as a whole and for the legislature, and we're in the process of putting our budget together like everybody does every year. Most of the health exchanges across the country were set up with a revenue source at the beginning. We were not. There are 3 or 4 states that have executive orders. The others have some kind of statutory authority. Some are quasi-public, some are state agencies, some are nonprofits. And so there are a range of options in terms of how you pay for it. There are a range of things that we can do going forward.
What do you want to see?
It's not what I want. It's the range of options. Yeah, and I have
18 to 24 million, right?
And the range of options go from assessments on claims to premium assessments just for people in the exchange. They range from doing the kind of data and analytics that are going to make it possible to save money in the long run to just doing an eligibility system.
Let me ask you,
lots of choices.
Christy, as I listened to your testimony before the House Finance Committee more recently, and the chairman, Helio Mello, sounded a mix of skeptical and concerned about the budget that you were proposing. And as you say, he and his committee and then the full assembly has the final say. What happens if you don't get even 18 million? What if they say we're running it on 12 million? You know, is that a negotiable number?
Sure, everything's negotiable, right?
Well, there must be some basic level. I mean, if they said no budget, Christy.
No, if there's no budget, then the federal government comes in and runs it. I mean, at the end of the day, it's a choice that we make as a state, right? These are the range of things we could do. My argument is there are a whole lot of things we haven't done over the past 20 years that have led us to this point. For a relatively small amount of money, we can start doing the data and analytics that are necessary to ask the question. And I will tell you, after 30 years in this business, at the end of this year, next year, I want to be able to look back and say, okay, we spent X amount of money in new subsidies for people to buy health insurance, in tax credits, federal dollars, to buy health insurance. We spent money to get people enrolled and provide this customer service. At the end of the day, did it actually lead to people who were able to work more days at work, who were more productive at work, kids who were able to learn at school because they were healthier? I want to know across sectors what the impact is. Those are some of the questions.
Arlene asked good questions about competition. I want to quickly ask, first, you've mentioned the Connecticut co-op. Are you going to let the co-op, this is a new kind of insurance plan,
absolutely.
You're going to let the co-op into Rhode Island's exchange?
They have to go, they're going to have to go through a regulatory process to be certified in the state, but right now it looks like they may well be able to get there. So we'll have Connecticut co-op, we'll have Tufts New England. And we're also going to be very aggressively this year looking at, now that we've got the groundwork laid, we have full employee choice, we have key things, we're going to aggressively begin to look at what are some of the other models that could be used.
The other question I had is, New York Times reported that Blue Cross's national multi-state plan, which is supposed to be a key way to bring competition to places like Rhode Island, will operate in 30 states, and Rhode Island wasn't on the list. Why aren't we on that list?
They make decisions. I mean, these are business decisions that insurance companies make about where they want to play.
So your office didn't say you can't come in?
We didn't go and no. And we didn't go and solicit them because, again, we're laying the groundwork for what needs to be here in the first year.
Did you say
there's lots of options?
Did you say Health Connection is going to deal with complaints? Because right now, as you know, there's an infrastructure at the Department of Business Regulation, Insurance Division. However, but they're used to processing these kinds of complaints. But your group now is going to
We're doing it in collaboration with OHIC, with the Office of the Health Insurance Commissioner. So what we've tried to do is consolidate those functions and work together and have many more people who can take those kinds of
but two different jurisdictions, in effect, right? I mean, how do you avoid, in a way, that's a duplicate bureaucracy.
No, not at all, not at all. This is the beautiful thing about what happened in Rhode Island. You go nationally all the time.
Yes, I do.
Go talk to all the national folks in the insurance industry or the insurance regulation. No state worked the way that we did to reduce the regulatory and administrative functions, to streamline this so that we could get to where we are today. And that's exactly what we're doing with...
I'm talking about the complaint factor, because they have tools that they can utilize under the statutes.
And we're using those tools.
But you don't have statutory authority, for example, to fine anyone,
they
conduct a hearing.
They do those things.
But if this gets expanded, the expansion should be theirs, not the Health Connector, because you don't have the authority to do any of the constituent elements of that investigation.
But
they can subpoena in records, etc.
But this is a customer.
But you don't.
This is a customer service receipt of complaints. It's not the processing of them. So in other words, if you go to OHIC, they don't have the capacity to receive the complaints, to receive the issues.
To date they have. I mean, they do a good job.
Well, it depends on who you talk to. OHIC was delighted to be part of this process. So this is not something that got built without tremendous collaboration across departments.
I'm just saying you don't have the statutory
we have
authority.
1 minute left, Darlene.
That's the problem. And push comes to shove, they are the people that take the action.
And
so
they
you want
will
you want
continue
the
to.
24 million or up to
No,
24
no,
million,
no.
among other things, to take the complaint and pass it over.
No,
because you can't do anything with it once you get the complaint except pass it over. You have no authority.
No, the idea was, again, OHIC.
You don't have enforcement authority, do you, right now?
Not
for
not
complaint.
for market. We have enforcement authority from a contractual perspective with the plans that we've signed on. There are a whole series of issues here. So this is not we're not duplicating and we're not replacing. We're actually providing a funnel so that we can work together and accomplish more.
Christy, 30 seconds left. Put out the website so people can explore.
The website is healthsourceri.com. And the phone number for the call center is 1-855-840-4774. And put the 1 on first because there's some poor woman out there whose phone number is 855.
Christine Ferguson, HealthSource Rhode Island. Thanks for joining us. We'll see you next week on News.